There is a health crisis unfolding right now that receives a fraction of the attention it deserves relative to its actual impact on the lives of people over 60. It is not a new disease. It is not a novel pathogen. It is something far more ordinary looking, so ordinary that most of the people affected by it do not recognize it as a health condition at all. They recognize it as a feeling, a familiar, persistent, quietly painful feeling that they may have been carrying for months or years, often without a name for it, often without realizing how profoundly it is affecting every dimension of their health. That feeling is loneliness. And the evidence for its effects on the physical health of older adults is substantially more alarming than most people, including many physicians, fully appreciate. I am Dr. John. I work in preventive health and senior wellness. And today I want to have a genuinely complete conversation about loneliness and social isolation in older adults. Not the surface-level reminder to stay connected that you have probably heard before, but an honest, evidence-grounded account of what social disconnection actually does to an aging body, why it is so prevalent, why it is so hard to address, and what approaches the research suggests are most genuinely effective. Before we go further, I want to ask you something directly. Leave a comment with your age and whether you feel you have enough genuine connection in your daily life. Not acquaintances, not people you see occasionally. People with whom you feel genuinely known and genuinely cared about. I read every comment, and your honest answer to that question matters more for this conversation than almost anything else. Let me start with the research, because the magnitude of the health effects is the necessary foundation for taking this seriously. The most frequently cited finding in this area comes from a landmark meta-analysis examining data from studies following hundreds of thousands of people over time. The conclusion was that social isolation and loneliness were associated with mortality risk comparable to smoking 15 cigarettes daily and substantially greater than the mortality risk associated with obesity, physical inactivity, or heavy alcohol consumption. This finding was not produced by a marginal research group or published in an obscure journal. It has been cited thousands of times and has been substantially replicated across subsequent research. The Surgeon General of the United States issued an advisory in 2023 formally identifying loneliness and social isolation as a public health epidemic, estimating that approximately half of American adults reported measurable loneliness even before the disruptions of the pandemic years. Among older adults specifically, the proportion reporting significant loneliness and social isolation is considerably higher than in the general adult population, for reasons I will explain shortly. The U.S. Department of Health and Human Services has estimated that social isolation increases the risk of premature death by approximately 26%, comparable in magnitude to the mortality risk associated with several conditions that receive far more clinical attention and public health resources. An analysis using data from the Health and Retirement Study, one of the most comprehensive longitudinal studies of aging in the United States, found that lonely older adults showed significantly accelerated cognitive decline compared to their more socially connected counterparts, with the difference remaining after accounting for depression, baseline cognitive function, and multiple other confounders. These are not soft, subjective findings about life satisfaction. They are hard data about measurable differences in mortality, cognitive function, and physical health outcomes, produced by one of the most thoroughly studied risk factors in contemporary health research. Why do social isolation and loneliness produce these effects? The mechanisms are multiple, interacting, and increasingly well characterized by researchers. The physiological stress response is the primary pathway. When humans experience loneliness, particularly chronic loneliness sustained over time, the brain interprets social disconnection as a threat signal. This is not metaphorical. From an evolutionary perspective, for our ancestors, being excluded from social groups was genuinely life-threatening. Since survival depended on collective effort and mutual protection, the brain's threat detection systems respond to chronic loneliness by activating the hypothalamic pituitary adrenal axis and sustaining an elevated cortisol output that, in the short term, is adaptive, but in the long term is profoundly damaging to multiple organ systems. Chronically elevated cortisol promotes systemic inflammation through multiple pathways, contributing to the elevated background inflammatory state that researchers call inflammaging, and that underlies virtually every major age-associated disease from cardiovascular disease to neurodegenerative conditions. It impairs immune function in specific ways, reducing the body's ability to mount effective responses to infectious agents, while simultaneously increasing inappropriate inflammatory responses to non-infectious stimuli. It damages the hippocampus, the brain region most critical for memory formation and most vulnerable to Alzheimer's disease pathology. And it disrupts sleep architecture, reducing the restorative deep sleep phases during which the glymphatic system clears metabolic waste from brain tissue. Research on the specific inflammatory pathways activated by loneliness has found that lonely individuals show elevated expression of genes involved in inflammatory signaling and reduced expression of genes involved in antiviral responses, creating a biological profile that increases susceptibility to chronic disease while reducing resistance to acute infection. This pattern, described in research as a conserved transcriptional response to adversity, was initially identified in response to acute stress, but has been found to be strongly activated by chronic social isolation. Sleep disruption represents a second major mechanism. Loneliness is consistently associated with poorer sleep quality, more frequent nighttime awakenings, and reduced slow-wave sleep. The mechanisms include heightened physiological arousal and hypervigilance that persists into the night, the absence of the co-regulatory social signals that historically helped synchronize human sleep patterns, and the mental preoccupation with social concerns that activates the default mode network during periods when the sleeping brain should be consolidating and clearing rather than processing. Poor sleep quality, as I have discussed in previous conversations, has cascading effects on cognitive function, immune regulation, metabolic health, and mood. When loneliness is producing chronically disrupted sleep across months and years, the downstream health consequences compound in ways that are difficult to attribute to any single cause, but are nonetheless real and measurable. Behavioral pathways represent the third category of mechanism. People experiencing chronic loneliness are less likely to engage in health-promoting behaviors, including physical activity, dietary attention, medical care seeking, and medication adherence. Social connection provides accountability, motivation, and meaning that sustains health behaviors across time. Its absence removes these supports, making it considerably harder to maintain the habits that protect health in later life. This behavioral pathway operates somewhat independently from the physiological stress pathway, contributing to health outcomes through an entirely separate channel. The cognitive engagement pathway is particularly relevant for dementia risk specifically. Human social interaction is among the most cognitively demanding activities that exists. A genuine conversation requires simultaneously attending to another person's words, interpreting their tone and emotional register, drawing on semantic and episodic memory, formulating responsive thoughts, managing the social dynamics of the exchange, and producing coherent, contextually appropriate speech. This sustained complex engagement maintains the neural systems involved in higher-order cognitive function in ways that more passive activities simply cannot replicate. Research has found that cognitively stimulating social engagement is one of the strongest behavioral predictors of maintained cognitive function in later life, and that its effects appear to operate through the development of what researchers call cognitive reserve, the accumulated neural resources that allow the brain to continue functioning effectively despite accumulating underlying pathology. Social isolation deprives the brain of this ongoing stimulus, accelerating cognitive decline independently of other risk factors. Now let me address why loneliness and social isolation are so prevalent among older adults specifically, because understanding the causes is essential for addressing them. Life transitions specific to later life are the most significant contributing factor. Retirement removes the social structure that work provided, often quite abruptly, eliminating daily contacts, purpose-giving roles, and the social identity that professional life sustained. The death of a spouse or long-term partner, one of the most painful experiences of human life at any age, simultaneously removes the most intimate social connection and dramatically alters social patterns that were built around the couple relationship. Adult children who relocate for professional reasons create geographic distances that are genuinely painful for older parents. The death of long-term friends, particularly in the 7th, 8th, and 9th decades of life, leaves gaps in the social network that become progressively harder to fill as the social opportunities for meeting potential new friends narrow. Geographic factors contribute substantially. Suburban and rural-built environments, in which car ownership is typically required to reach social venues and where residential isolation is common by design, create structural barriers to spontaneous social contact that are particularly challenging for older adults who have reduced driving capability. Neighborhoods that lack genuinely walkable gathering spaces, libraries, community centers, parks with seating, and public transit that is accessible without significant physical challenge impose social isolation on older adults as a function of environment rather than individual choice. Health factors create a vicious cycle. Physical conditions that limit mobility, hearing loss that makes conversation exhausting and embarrassing, vision impairment that makes reading and screen use difficult, depression that produces withdrawal from social situations, and cognitive changes that make social interaction feel more effortful, all reduce social engagement in ways that then worsen the health conditions that produced the limitation in the first place. Digital literacy gaps create an increasingly significant barrier in a world where social connection has migrated substantially to digital platforms. Older adults who did not develop comfort with technology during their working years face a steeper learning curve for staying connected through the digital channels that have become primary for many younger family members and friends. This is particularly acute for very old adults who may have limited physical mobility, making in-person connection more dependent on others coming to them. Ageism in the broader culture contributes to social marginalization in ways that are sometimes subtle and sometimes quite overt. Older adults are underrepresented in social spaces, undervalued in many professional and community contexts, and subject to stereotypes that frame them as cognitively diminished, physically dependent, or simply less interesting and relevant than younger adults. These cultural messages, when internalized, can produce social withdrawal driven by the painful anticipation of rejection or dismissal. What does the evidence say about what actually helps? I want to be honest here about something that the research on loneliness interventions has made clear. Not all approaches that seem intuitive are equally effective. Simply increasing the frequency of social contact, adding more group activities to someone's schedule, or encouraging greater technology use produces inconsistent results because they do not necessarily address the underlying experience of loneliness. Loneliness is not simply the absence of social contact. It is the subjective experience of a gap between the social connection you have and the social connection you genuinely need. Someone can be surrounded by people and feel profoundly lonely if those interactions feel superficial, obligatory, or disconnected from their genuine self. And someone with relatively few social contacts can feel genuinely connected if those contacts are characterized by authentic mutual care and understanding. This distinction matters for what kinds of interventions actually produce change. Approaches that increase the quantity of social contact without improving its quality tend to produce modest and often temporary improvements in loneliness. Approaches that specifically target the quality and meaningfulness of social connection, or that address the cognitive and emotional patterns that maintain loneliness even in the presence of adequate social opportunity, tend to produce more durable change. Cognitive behavioral therapy and related approaches have shown the most consistent evidence for reducing loneliness specifically because they address the maladaptive social cognitions, the expectations of rejection, the hypervigilance for signs of exclusion, and the self-protective withdrawal that maintain and deepen loneliness even when social opportunity exists. These patterns are not weaknesses or character flaws. They are learned responses to painful social experiences that, once established, tend to perpetuate themselves unless directly addressed. Social prescribing, an approach in which healthcare providers connect patients experiencing loneliness and social isolation to community resources and activities through a formalized referral process, has shown promising results in several healthcare systems, particularly the UK National Health Service, where it has been implemented most extensively. The evidence suggests that social prescribing produces meaningful improvements in well-being and reduced healthcare utilization, particularly when the referring process is supported by a dedicated link worker who helps patients navigate to and sustain engagement with community resources. Intergenerational programs, which bring older adults into sustained contact with children and younger adults through structured shared activities, have shown particular promise in research. These programs appear to be more effective than programs connecting older adults exclusively with same-age peers, possibly because the intergenerational context creates natural role differences that give older participants a clear contribution to make, which supports the sense of purpose and being genuinely valued that is a distinct component of social well-being. Community integration approaches that address the built environment and structural conditions producing social isolation, creating walkable neighborhoods, investing in accessible public transit, maintaining and improving community gathering spaces are the interventions with the largest potential population-level impact, but also the longest time horizons for implementation. They are nonetheless worth advocating for because the structural conditions of isolation are not simply choices made by isolated individuals. Technology-mediated social contact has shown mixed results in research. Video calling produces substantially better outcomes than telephone-only contact because the visual channel provides the social cues that voice alone lacks. Simple, intuitive technology interfaces designed specifically for older adults with limited prior digital experience show better adoption rates than standard platforms. But technology-mediated contact appears to work best as a complement to in-person contact rather than a replacement for it. For older adults who cannot maintain in-person contact due to mobility or health limitations, supported access to video communication with family and friends provides genuine benefit. But for those with physical capacity for in-person engagement, technology is not an adequate substitute. Practical recommendations that I want to be genuinely concrete about, because abstract encouragement to stay connected is not what most people who are experiencing loneliness actually need. If you are experiencing loneliness, start by naming it honestly. There is still enough social stigma around loneliness that many people spend considerable energy denying or minimizing what they are actually experiencing, and this avoidance prevents them from taking the action that would actually help. Naming loneliness as a real experience with real health consequences and allowing yourself to treat it as a legitimate health concern that deserves genuine attention is the necessary first step. If your loneliness is accompanied by the social withdrawal, loss of interest in activities, and persistent low mood that characterizes depression, addressing the depression specifically through professional support, therapy, or medication or both is the most important first intervention because depression will actively undermine any other social engagement effort until it is adequately addressed. Identify the specific barriers to connection that are most relevant to your situation. If hearing loss is making social interaction exhausting and humiliating, getting hearing aids evaluated and fitted is a connection intervention, not just a sensory one. If transportation is the barrier, exploring community transportation services, ride-sharing arrangements with neighbors, or conversations with family members about creative solutions addresses the actual obstacle. If mobility is the barrier, finding ways to bring social connection into your home environment rather than only seeking it outside becomes more important. Seek activities that provide structured, recurring social contact around a shared purpose rather than purely social contact for its own sake. Activities organized around a genuine shared interest, a garden club, a book group, a volunteer organization, a craft group, a religious community, a choir, tend to produce more durable engagement and more meaningful connection than purely social activities, because the shared purpose provides both a reason to continue showing up and a natural foundation for conversation and genuine connection. Consider volunteering specifically because the evidence for its benefits in older adults for social connection, purpose, and overall well-being is unusually consistent and robust. Volunteering provides structured social contact, a genuine sense of contribution and being needed, and a context in which older adults are valued for what they bring rather than simply tolerated or managed. The specific cause matters less than the genuine sense of contribution and the social integration it provides. If you have children, grandchildren, or other family members in your life, consider having an honest conversation about the role that social connection plays in your health, using some of the evidence I have shared today. Family members who understand that supporting social connection in their older relatives is a genuine health intervention, comparable in importance to medication adherence or medical appointments, may be more likely to prioritize making time for visits, calls, and including their older relatives in social activities. Address the inner obstacles. Chronic loneliness can produce a self-reinforcing psychological cycle in which the pain of social disconnection makes new social attempts feel risky. The fear of rejection makes initiating connection feel frightening, and the resulting withdrawal further deepens the disconnection. Recognizing this cycle for what it is, a learned protective response that is now causing more harm than protection, is essential for breaking it. Working with a therapist who understands the specific psychological dimensions of loneliness in older adults can be genuinely valuable here, particularly if social anxiety, depression, or grief are contributing factors. Let me close with something that I think is important to say directly. The loneliness epidemic affecting older adults is not primarily a failure of individual effort or social skill. It is substantially a consequence of how we have organized society, how we have designed communities, how we have structured the life transitions of later adulthood, and how we have culturally positioned older adults relative to the rest of society. Addressing it fully requires changes at every level: individual, family, community, and societal. But while those larger changes develop, individual older adults are making daily decisions about how to engage with the social world around them. Those decisions matter for their health in ways that are as well documented as any lifestyle factor in medicine. Having the most accurate and complete information about why they matter and what the evidence suggests about what actually helps is not a luxury. It is genuinely essential health knowledge. You deserve that knowledge, and you deserve to have it taken seriously. This is Dr. John. Your connections are your health. Protect them accordingly. I will see you in the next one.